So my name is Kevin Connolly, and for the week 6 case study, I chose case number 2 and case number 3. So I'll start with case number 2. So for the metabolism and maturation of the VLDL particles, the VLDLs formed after the transfer of triglycerides and the cholesterol esters in the endoplasmic reticulum to the ApoB100. The VLDL particles carry lipoproteins that are metabolized by lipoprotein lipase, which form free fatty acids and IDL, and the IDL is then converted to LDL, which is taken up primarily by the liver and other peripheral tissues. The IDL particles then acquire ApoB from HDL for removal by the liver via the circulatory system, and then the IDL is also hydrolyzed by hepatic lipase, which leads the apolipoproteins to transfer to other lipoproteins, leading to the formation of LDL. And for non-alcoholic fatty liver disease, for its manifestation and what processes the non-alcoholic fatty liver disease, it could be caused from hepatic lipogenesis as a consequence of insulin resistance. Research has shown that adiponectin production increases, leading to insulin resistance due to a variety of genetic and lifestyle factors. The adiponectin is thought to inhibit the inflammatory cytokines such as TNF alpha and IL-18 that would contribute to the healing of a hepatic injury should the patient sustain one. The adiponectin is also thought to have antifibrotic activity, which would inhibit the hepatic repair. And for case number 3, with the blood values and the fatigue and chest pain of the 48-year-old female on exertion. In terms of the patient's hormone status, she's most likely a diabetic. Her pancreas is not producing enough insulin for her needs, or their bodies also could also not be able to use the insulin properly to decrease the blood glucose after eating, which would be more the type 2 diabetes. Type 2 diabetes has been shown to lead to more adipocyte deposition and obesity in individuals. In obese individuals, the growing adipocytes will store additional triglycerides and maintain lipolysis even during the fasted state. The patient's blood work shows the increased LDL concentration compared to HDL concentration, which would follow the increased triglyceride production from the increased adipocyte function. And in terms of the 3 possible treatments that were recommended for statins, they work to lower LDL through the inhibition of HMG CoA reductase, which prevents the formation of mevalonic acid. This leads to an increase in the cell surface LDL receptor expression, which allows the increased clearance of LDL from the bloodstream. This leads to a decreased rate of atherosclerosis in the patient and cardiovascular disease. The most common side effect of the statin use is statin-associated muscle symptoms, which typically will involve myalgia and tendinosis of the lower extremities due to an elevated creatinine kinase level. The PCSK9 inhibitors work to block the proteolytic enzyme PCSK9, and this enzyme destroys LDL receptors. The inhibitors will work as monoclonal antibodies to bind the free PCSK9. This process is going to allow more LCL particles to be processed out of the blood serum. The main side effect for the PCSK9 inhibitors is an injection site reaction, because these are not oral drugs, and there's a possible severe allergic reaction because these are immunosuppressive drugs that are viewed as a foreign body. When they enter the patient, this can elicit a immune response that can cause severe allergic reactions. And the bile acid sequestrants, they will act by reducing absorption of the bile acids in the intestine. They are excreted in the feces, which causes the hepatic cholesterol to convert to bile acid. This leads to the upregulation of hepatic LDL receptors and a subsequent decrease in LDL blood concentrations. The main side effect of bile acid sequestrants are gastrointestinal distress, such as constipation and vomiting, as this drug directly affects bile acid metabolism.